Question 1. A pregnant patient with a history of chronic hypertension develops new-onset proteinuria at 32 weeks. Which of the following is the most critical intervention? A. Administer magnesium sulfate. B. Initiate antihypertensive therapy. C. Perform a non-stress test. D. Prepare for immediate delivery. Answer: B. Initiate antihypertensive therapy. Rationale: the new onset of proteinuria suggests the development of preeclampsia. The priority is to manage the blood pressure to prevent complications such as stroke, kidney failure, or placental abruption. Magnesium sulfate is used for seizure prevention in severe preeclampsia or eclampsia, but blood pressure management is paramount in this situation. A non-stress test and preparation for delivery are not the first priority in this stage. Question 2. A woman at 34 weeks gestation is diagnosed with an ectopic pregnancy after presenting with sudden-onset severe pelvic pain and fainting. What is the next priority action? A. Begin IV fluid resuscitation. B. Administer methotrexate. C. Perform a laparoscopy to locate the pregnancy. D. Perform an ultrasound to confirm diagnosis. Answer: A. Begin IV fluid resuscitation. Rationale: in the case of a ruptured ectopic pregnancy with signs of shock, fainting, hypotension, immediate fluid resuscitation is the priority to stabilize the patient. Administering methotrexate, performing laparoscopy, or an ultrasound can be performed later once the patient's condition is stabilized. Question 3. A 38-week pregnant woman with a history of diabetes and hypertension presents with a headache, visual disturbances, and hyperreflexia. What is the most likely diagnosis? A. Gestational hypertension. B. Preeclampsia with severe features. C. Chronic hypertension with exacerbation. D. Eclampsia. Answer: B. Preeclampsia with severe features. Rationale: headache, visual disturbances, and hyperreflexia are signs of severe preeclampsia. These symptoms, along with her history of hypertension and diabetes, suggest preeclampsia with severe features, which requires urgent management. Gestational hypertension alone doesn't include these symptoms, while eclampsia is characterized by seizures. Chronic hypertension with exacerbation would not typically cause these neurological symptoms. Question 4. A patient with placenta previa presents at 36 weeks gestation with painless vaginal bleeding. What is the first priority intervention? A. Administer corticosteroids for fetal lung maturation. B. Assess fetal heart rate and maternal vital signs. C. Prepare for cesarean delivery. D. Perform a vaginal exam to assess the bleeding source. Answer: B. Assess fetal heart rate and maternal vital signs. Rationale: in placenta previa, the first priority is to assess fetal heart rate and maternal vital signs to evaluate the severity of bleeding and fetal well-being. Administering corticosteroids and preparing for cesarean delivery may be necessary depending on the severity of bleeding, but the immediate assessment of maternal and fetal status takes precedence. Performing a vaginal exam can exacerbate bleeding and is contraindicated. Question 5. Which pharmacologic agent is considered first-line treatment for hyperemesis gravidarum that has not responded to IV fluids? A. Ondansetron. B. Promethazine. C. Metoclopramide. D. Doxylamine-pyridoxine combination. Answer: D. Doxylamine-pyridoxine combination. Rationale: the doxylamine-pyridoxine combination is considered the first-line pharmacologic treatment for hyperemesis gravidarum that has not responded to IV fluids. Ondansetron and promethazine are effective antiemetics, but are typically used for other nausea-related conditions. Metoclopramide is another antiemetic, but the doxylamine-pyridoxine combination has the most evidence supporting its use in pregnancy. Question 6. A 30-year-old woman with gestational diabetes is in labor at 40 weeks. The fetal monitoring reveals a large fetus. Which of the following is the most appropriate management option? A. Schedule an immediate cesarean section. B. Allow for a vaginal delivery with assistance. C. Induce labor immediately. D. Perform an episiotomy to assist delivery. Answer: B. Allow for a vaginal delivery with assistance. Rationale: In most cases, a vaginal delivery is appropriate for a large fetus macrosomia, but it may require assistance such as forceps or vacuum extraction. Immediate cesarean section is not necessary unless there are other indications, for example, fetal distress. Inducing labor and performing an episiotomy are not routine measures for delivering a large baby. Question 7. What is the most common cause of uterine rupture during labor? A. Overuse of oxytocin. B. Fetal malpresentation. C. Previous cesarean section. D. Maternal obesity. Answer: A. Overuse of oxytocin. Rationale: the most common cause of uterine rupture is overuse of oxytocin, which can cause excessive uterine contractions, leading to a rupture. Previous cesarean sections increase the risk of rupture, but oxytocin-induced rupture is more common. Fetal malpresentation and maternal obesity are risk factors for other complications, but are not as strongly linked to uterine rupture. Question 8. In a patient with gestational hypertension at 30 weeks gestation, which of the following is the most appropriate management strategy? A. Immediate induction of labor. B. Initiate bed rest and monitor vital signs. C. Administer antihypertensive medication. D. Prepare for cesarean delivery. Answer: B. Initiate bed rest and monitor vital signs. Rationale: in gestational hypertension, the main treatment is monitoring and controlling blood pressure. Bed rest and regular vital sign assessments are key components of care, but induction of labor or cesarean delivery is not indicated unless the hypertension becomes severe or complications develop. Antihypertensive medications may be used, but they are not the first line of treatment. Question 9. What complications should the nurse suspect if a postpartum patient experiences a sudden drop in blood pressure and tachycardia after delivery? A. Postpartum hemorrhage. B. Preeclampsia. C. Pulmonary embolism. D. Endometritis. Answer: A. Postpartum hemorrhage. Rationale: a sudden drop in blood pressure and tachycardia after delivery are classic signs of postpartum hemorrhage. This condition requires immediate intervention to prevent shock. Preeclampsia, pulmonary embolism, and endometritis are all possible complications, but they are less likely to present with this combination of symptoms immediately postpartum. Question 10. In a patient with an incomplete abortion at 12 weeks gestation, what is the first nursing action? A. Provide emotional support. B. Prepare for a dilation and curettage D&C. C. Obtain a detailed obstetric history. D. Monitor vital signs and assess for bleeding. Answer: D. Monitor vital signs and assess for bleeding. Rationale: in an incomplete abortion, the priority is to monitor vital signs and assess for bleeding to ensure that the patient is stable. Emotional support and obtaining an obstetric history are important, but not the first priority. A dilation and curettage may be needed, but it comes after stabilization of the patient. Question 11. A patient with preeclampsia at 36 weeks gestation is experiencing severe headaches and epigastric pain. What complication should the nurse anticipate? A. Eclampsia. B. Placental abruption. C. HELLP syndrome. D. Fetal demise. Answer: C. HELLP syndrome. Rationale: severe headaches and epigastric pain are signs of HELLP syndrome. Hemolysis, elevated liver enzymes, low platelets. A severe complication of preeclampsia. Eclampsia is marked by seizures. Placental abruption can present with vaginal bleeding, and fetal demise is not directly indicated by these symptoms. Question 12. Which of the following is an early indication of maternal sepsis after a cesarean section? A. Increased pulse rate and fever. B. Abdominal distension. C. Elevated blood pressure. D. Hemorrhage and hypovolemia. Answer: A. Increased pulse rate and fever. Rationale: early signs of maternal sepsis after a cesarean section include fever and tachycardia, indicating an infection. Abdominal distension, elevated blood pressure, and hemorrhage are later or more severe signs of complications such as peritonitis or hypovolemic shock. Question 13. A pregnant patient with a history of asthma is experiencing shortness of breath and wheezing. Which medication should be avoided in this patient? A. Albuterol. B. Magnesium sulfate. C. Terbutaline. D. Misoprostol. Answer: D. Misoprostol. Rationale: misoprostol is contraindicated in pregnancy as it can cause uterine contractions. Albuterol, magnesium sulfate, and terbutaline are used to manage asthma and preterm labor. They are safe in pregnancy when used as prescribed. Question 14. Which complication is most commonly associated with multifetal pregnancies? A. Hyperemesis gravidarum. B. Gestational hypertension. C. Preterm labor. D. Gestational diabetes. Answer: C. Preterm labor. Rationale: multifetal pregnancies are most commonly associated with an increased risk of preterm labor due to the greater uterine stretch and higher likelihood of multiple placentas. Hyperemesis, hypertension, and diabetes are also common, but are not as directly linked to multiple gestations as preterm labor. Question 15. Which diagnostic test is essential to confirm a diagnosis of gestational trophoblastic disease (GTD)? A. Ultrasound. B. Serum HCG levels. C. Doppler flow studies. D. Amniocentesis. Answer: B. Serum HCG levels. Rationale: elevated serum HCG levels are a key diagnostic marker for gestational trophoblastic disease. Ultrasound is used to visualize the molar pregnancy, but HCG levels provide the initial diagnostic clue. Doppler flow studies and amniocentesis are not indicated for the diagnosis of GTD. Question 16. What is the first intervention for a patient diagnosed with a prolapsed umbilical cord? A. Administer oxygen to the mother. B. Position the mother in Trendelenburg. C. Perform an emergency cesarean section. D. Apply pressure to the presenting part. Answer: B. Position the mother in Trendelenburg. Rationale: the priority in umbilical cord prolapse is to relieve pressure on the cord by positioning the mother in Trendelenburg or knee-chest position. Oxygen is administered after this intervention. Emergency cesarean is performed if the baby is in distress, and applying pressure to the presenting part should be done by the provider, not the nurse. Question 17. What maternal complication is associated with an increase in the incidence of uterine atony postpartum? A. Diabetes mellitus. B. Hypertension. C. Retained placenta. D. Obesity. Answer: C. Retained placenta. Rationale: retained placenta is a significant risk factor for uterine atony postpartum because it prevents the uterus from contracting properly, leading to increased bleeding. Diabetes, hypertension, and obesity can complicate pregnancy, but they are not as directly linked to uterine atony as retained placenta. Question 18. Which is a major risk factor for developing a uterine rupture during labor? A. Prolonged second stage of labor. B. Preterm labor. C. Overuse of oxytocin. D. Advanced maternal age. Answer: C. Overuse of oxytocin. Rationale: overuse of oxytocin increases the risk of uterine rupture due to overstimulation of the uterus. Prolonged labor, preterm labor, and advanced maternal age increase the risk for other complications, but not as significantly as oxytocin overuse in uterine rupture. Question 19. What is the primary goal in the management of HELLP syndrome? A. Control blood pressure. B. Prevent seizures. C. Deliver the fetus. D. Correct liver dysfunction. Answer: C. Deliver the fetus. Rationale: the primary goal in managing HELLP syndrome is to deliver the fetus as soon as it is safe to prevent further maternal and fetal complications. Blood pressure control, seizure prevention, and liver dysfunction correction are important, but delivery remains the priority. Question 20. What is the primary concern for the nurse when caring for a postpartum patient who develops a deep vein thrombosis, DVT? A. Preventing further clot formation. B. Monitoring for signs of hemorrhage. C. Administering pain relief. D. Encouraging early ambulation. Answer: A. Preventing further clot formation. Rationale: the primary concern with a postpartum DVT is preventing further clot formation and complications like pulmonary embolism. Monitoring for hemorrhage, pain relief, and early ambulation are important interventions, but come after preventing the clot from worsening. Question 21. A 25-year-old pregnant woman presents at 28 weeks gestation with signs of severe preeclampsia. What is the most appropriate immediate nursing action? A. Administer magnesium sulfate. B. Monitor fetal heart rate. C. Initiate antihypertensive therapy. D. Prepare the patient for cesarean delivery. Answer: A. Administer magnesium sulfate. Rationale: magnesium sulfate is used to prevent seizures in patients with severe preeclampsia. Antihypertensive therapy and fetal monitoring are important, but come after magnesium sulfate administration in severe preeclampsia cases. Immediate cesarean delivery is not indicated unless the condition worsens. Question 22. A patient diagnosed with a molar pregnancy presents with vaginal bleeding and an enlarged uterus at 10 weeks. What is the next step in management? A. Perform a dilation and curettage DNC. B. Administer methotrexate. C. Perform a hysterectomy. D. Initiate an ultrasound for fetal viability. Answer: A. Perform a dilation and curettage DNC. Rationale: the primary treatment for a molar pregnancy is a dilation and curettage DNC to remove the abnormal tissue. Methotrexate is used for certain types of trophoblastic disease, but DNC is the first step. A hysterectomy is not necessary unless the molar pregnancy persists. An ultrasound is important, but should follow the DNC to assess the tissue removal. Question 23. A patient at 32 weeks gestation with a history of gestational diabetes presents with sudden weight gain and edema. What is the most likely diagnosis? A. Preterm labor. B. Preeclampsia. C. Heart failure. D. Gestational hypertension. Answer: B. Preeclampsia. Rationale: sudden weight gain and edema are classic symptoms of preeclampsia, especially in the context of gestational diabetes. Preterm labor and gestational hypertension may involve some symptoms, but not as specifically as preeclampsia, and heart failure is less likely in pregnancy without other risk factors. Question 24. A pregnant woman at 24 weeks gestation presents with severe pelvic pressure, cramping, and regular contractions. What is the best initial intervention? A. Administer intravenous fluids. B. Perform a non-stress test. C. Administer tocolytics to stop contractions. D. Prepare for immediate cesarean delivery. Answer: C. Administer tocolytics to stop contractions. Rationale: the best initial intervention for preterm labor at 24 weeks is the administration of tocolytics to attempt to stop the contractions. Intravenous fluids and a non-stress test may also be part of the management, but tocolytics are the priority for stopping labor. Immediate cesarean delivery is not indicated unless fetal distress or other complications are present. Question 25. A 28-year-old woman at 38 weeks gestation has a diagnosis of oligohydramnios. What is the most likely maternal complication that needs monitoring? A. Preterm labor. B. Placental insufficiency. C. Postpartum hemorrhage. D. Preeclampsia. Answer: B. Placental insufficiency. Rationale: oligohydramnios is often associated with placental insufficiency, which can affect fetal growth and well-being. Monitoring for signs of fetal distress and monitoring the placenta is key. Preterm labor, postpartum hemorrhage, and preeclampsia are less directly linked to oligohydramnios. Question 26. A pregnant woman at 37 weeks presents with a sudden drop in fetal movement and decreased fetal heart rate variability. What is the priority action? A. Perform a biophysical profile. B. Perform a non-stress test. C. Administer oxygen to the mother. D. Prepare for emergency cesarean delivery. Answer: D. Prepare for emergency cesarean delivery. Rationale: decreased fetal movement and abnormal fetal heart rate variability are signs of possible fetal distress, and an emergency cesarean delivery may be required if the fetal well-being is compromised. A biophysical profile and non-stress test are useful, but come after stabilization and further evaluation. Oxygen may be administered to the mother to improve fetal oxygenation. Question 27. A 35-year-old woman with a history of smoking presents with sudden onset severe abdominal pain, nausea, and vaginal bleeding at 20 weeks gestation. What is the most likely diagnosis? A. Placental abruption. B. Ectopic pregnancy. C. Miscarriage. D. Intrauterine fetal death. Answer: A. Placental abruption. Rationale: placental abruption is the most likely diagnosis, especially given the combination of abdominal pain, vaginal bleeding, and a history of smoking. This condition is characterized by the premature detachment of the placenta. Ectopic pregnancy and miscarriage typically present at earlier gestations, and intrauterine fetal death doesn't usually present with active bleeding at this stage. Question 28. Which of the following is a key nursing intervention for a patient diagnosed with chorioamnionitis during labor? A. Administer antibiotics as prescribed. B. Perform a pelvic exam to check cervical dilation. C. Initiate fetal monitoring every 30 minutes. D. Administer magnesium sulfate for seizure prevention. Answer: A. Administer antibiotics as prescribed. Rationale: chorioamnionitis is a bacterial infection of the amniotic sac, and antibiotics are the primary treatment. Performing a pelvic exam, initiating fetal monitoring every 30 minutes, and administering magnesium sulfate are secondary to antibiotic treatment. Infection control is the priority in this case. Question 29. A pregnant patient develops a fever, abdominal tenderness, and foul-smelling lochia on day 3 postpartum. What is the most likely diagnosis? A. Postpartum hemorrhage. B. Endometritis. C. Mastitis. D. Urinary tract infection. Answer: B. Endometritis. Rationale: endometritis is an infection of the uterine lining, commonly occurring postpartum. Symptoms include fever, abdominal tenderness, and foul-smelling lochia. Postpartum hemorrhage presents with excessive bleeding, while mastitis involves breast tenderness and UTI presents with dysuria, neither of which are typically accompanied by foul-smelling lochia. Question 30. A patient with a previous cesarean section is in labor at 40 weeks. The fetal heart rate monitor shows late decelerations. What is the priority intervention? A. Administer a uterine stimulant. B. Prepare for emergency cesarean delivery. C. Change the patient's position. D. Increase intravenous fluids. Answer: B. Prepare for emergency cesarean delivery. Rationale: late decelerations are typically indicative of uteroplacental insufficiency, and in a patient with a previous cesarean section, this may indicate uterine rupture. Emergency cesarean delivery is the most appropriate intervention. Changing the patient's position, increasing fluids, or administering uterine stimulants would not address the underlying issue in this case. Question 31. What is the most common cause of maternal death related to preeclampsia? A. Stroke. B. Eclampsia. C. Acute renal failure. D. Hemorrhagic shock. Answer: A. Stroke. Rationale: the most common cause of maternal death related to preeclampsia is stroke, which can result from severe hypertension leading to vascular damage in the brain. Eclampsia, seizures, and acute renal failure are serious complications, but stroke is the leading cause. Hemorrhagic shock is typically associated with hemorrhage, not preeclampsia. Question 32. Which of the following is the most significant risk factor for developing deep vein thrombosis, DVT postpartum? A. Prolonged bed rest. B. Obesity. C. Previous DVT. D. Smoking. Answer: C. Previous DVT. Rationale: a history of previous DVT significantly increases the risk of developing a DVT postpartum due to the increased risk of blood clot formation. Prolonged bed rest, obesity, and smoking are also risk factors, but a previous DVT is the most significant factor for recurrence. Question 33. A patient with a history of hypertension presents with sudden onset severe headache, visual changes, and right-sided weakness. What is the priority nursing action? A. Assess blood pressure. B. Administer antihypertensive medication. C. Prepare for stroke management. D. Assess for signs of eclampsia. Answer: C. Prepare for stroke management. Rationale: the patient's symptoms suggest a stroke, which requires immediate intervention to minimize brain damage. Blood pressure should be assessed, but should not delay the preparation for stroke management. Administering antihypertensive medication and assessing for eclampsia are not the primary interventions in the case of suspected stroke. Question 34. A 24-year-old prima gravida at 26 weeks gestation with no known medical conditions presents with swelling in her feet, face, and hands. What is the most likely cause? A. Normal pregnancy edema. B. Preeclampsia. C. Deep vein thrombosis DVT. D. Heart failure. Answer: B. Preeclampsia. Rationale: preeclampsia is the most likely cause of swelling in the feet, face, and hands, especially after 20 weeks of gestation. While normal pregnancy edema is common, the severity of the swelling, along with other potential signs, makes preeclampsia a more likely diagnosis. DVT and heart failure are less common causes of edema at this stage of pregnancy. Question 35. What is the initial treatment for a postpartum patient presenting with severe perineal pain and swelling after vaginal delivery? A. Ice packs to the perineum. B. Sitz baths. C. Narcotic pain relievers. D. Application of heat packs to the perineum. Answer: A. Ice packs to the perineum. Rationale: ice packs are the first-line treatment for perineal pain and swelling after vaginal delivery. Ice helps reduce swelling and numbs the area. Sitz baths, narcotic pain relievers, and heat packs may be used later, but are secondary interventions. Question 36. A woman at 30 weeks gestation with a history of asthma presents with wheezing and shortness of breath. What is the first priority in management? A. Administer albuterol. B. Administer magnesium sulfate. C. Perform an ultrasound to assess fetal well-being. D. Administer corticosteroids for lung maturation. Answer: A. Administer albuterol. Rationale: albuterol is the first-line treatment for asthma exacerbations in pregnancy to relieve bronchospasm. Magnesium sulfate and corticosteroids are used in certain obstetric emergencies, but are not appropriate for treating asthma symptoms directly. An ultrasound for fetal well-being may be performed later. Question 37. A pregnant patient presents with sudden, severe lower abdominal pain and vaginal bleeding at 22 weeks gestation. What is the priority action? A. Administer intravenous fluids. B. Perform an ultrasound to confirm diagnosis. C. Prepare for emergency surgery. D. Assess fetal heart rate. Answer: B. Perform an ultrasound to confirm diagnosis. Rationale: the priority action in this situation is performing an ultrasound to confirm the diagnosis, e.g., miscarriage, placental abruption. Fluid resuscitation, emergency surgery, and fetal monitoring are important, but depend on the results of the ultrasound. Question 38. A 25-year-old woman with no prenatal care presents at 32 weeks gestation with severe abdominal pain and tenderness, nausea, and vomiting. What is the most likely diagnosis? A. Acute appendicitis. B. Gallbladder disease. C. Placental abruption. D. Ovarian torsion. Answer: C. Placental abruption. Rationale: placental abruption is the most likely diagnosis based on the severe abdominal pain, tenderness, and nausea. Gallbladder disease, appendicitis, and ovarian torsion are less likely in a pregnant woman with these symptoms, though they should be considered. Question 39. A pregnant patient is diagnosed with a urinary tract infection, UTI, at 30 weeks gestation. Which of the following is the most appropriate first-line treatment? A. Ciprofloxacin. B. Nitrofurantoin. C. Amoxicillin. D. Trimethoprim sulfamethoxazole. Answer: B. Nitrofurantoin. Rationale: nitrofurantoin is considered the first-line treatment for UTIs during pregnancy, as it is safe for both the mother and fetus. Ciprofloxacin and trimethoprim sulfamethoxazole are contraindicated in pregnancy. Amoxicillin is also used but may not be as effective in some resistant infections. Question 40. A patient with a history of epilepsy is pregnant at 24 weeks. Which medication should be avoided due to its teratogenic effects? A. Valproic acid. B. Levetiracetam. C. Lamotrigine. D. Phenytoin. Answer: A. Valproic acid. Rationale: valproic acid is known to have teratogenic effects, especially causing neural tube defects. Levetiracetam, lamotrigine, and phenytoin are generally considered safer during pregnancy, although any medication should be used cautiously and under the supervision of a healthcare provider.
If you found this video helpful, don't forget to like, subscribe, and share with your fellow nursing students. Hit the bell icon so you never miss an update. See you in the next one. Happy studying.